Yeah, I'd like to introduce our next speaker. He's going to be talking about the advocating for your care. And ever since I first met him, he's been an amazing person. And his ability to distill really technical stuff into a manner that we can really understand as a layperson. I'm not a scientist, I'm not a doctor, and I even understand what he's talking about. So that's an achievement in and of itself, his skill to do that. And also, I've met his patients over the years, and his compassion and his dedication to his patients shines through. And I think you'll come away with that realization also when you hear him speak. We were talking a little bit beforehand here, discussing. He is a big baseball fan, and he's talking about bobbleheads of all things. So who would have thought? You come to an ed forum and you talk about bobblehead dolls. So, he is a great representative of the doctors that care for us, and we really appreciate his efforts and his coming here every time to do this. Every time we ask, he never says no. So maybe that's a flaw, but to us, it's a benefit. So thank you.
Thank you, Peter. And the only rule I have for this morning is I'm from Denver, Colorado, and I like baseball, and anyone who even remotely follows baseball is probably aware that the Colorado Rockies are on pace for a modern era poor performance record. They're 9-48 so far. So if they keep it up, they'll have the record from the White Sox. So I've been tasked with talking about how to be a good patient. And so I love talking about this because this is what I do in my practice. I encourage my patients to be really involved in their care. And of course, I'm preaching to the choir here this morning, talking to the IWMF. But there's a skill to being a good patient and to getting the most in your health care. And I think I have some thoughts about this that I would like to share with you and to see if this helps you in your journey with WM. And also, I just want to make a comment. It's nice to see this audience just rebounding a little bit from the last 5 years. It's nice to see people showing up to the Ed Forum again. Hopefully we have a lot of people participating virtually in this. And I always tell my patients at home also, spread the word about how effective this is, and let's keep trying to make this event get back to where we were and exceed the pre-pandemic levels. So I'm in Denver, Colorado. I work at Colorado Blood Cancer Institute. And my practice is I see 3 diseases in my practice. I see multiple myeloma, I see Waldenstrom's, and I treat a rare disease called amyloidosis. So you and your healthcare team hopefully are going to have a long relationship. And like any long relationship, and I'm fortunate to have one of those, my spouse is here somewhere, probably having breakfast. Anyway, the groundwork needs to be laid and nurtured over time in order to optimize it. And so think about it. With your diagnosis, if all goes well, if you do like we expect the great majority of you to do, you may end up spending more time with your healthcare team than you did on your formal education. Think about that. And so if that's the case, then we should work as hard as we can to make that experience optimal. So our goal this morning is to help you be the best patient you can and to foster the best care you can from your doctors, your nurses, your entire healthcare team. And so you guys are starting with a huge advantage since you're here and you're already engaged with the IWMF. Now, the American Society of Clinical Oncology, that's ASCO, and I had a choice this weekend, by the way. The ASCO meeting is always this weekend. It's in Chicago, and it's at the McCormick Center, which is I hate the place. And so ASCO's a zoo, and there's very little blood cancer at ASCO. I thought, I could go to Chicago in the McCormick place, or I could go to the Florida coast, have nice weather, swim and play golf, and talk to WM people. That was a very difficult decision, but I landed on coming here instead. So, but the ASCO, they say for self-advocacy, they say it's a positive experience and often gives a person a sense of control in a time of uncertainty. And one of the things that a cancer diagnosis does is it can impact people's autonomy, where you feel like things might be out of your hands to to some extent, and that's a scary place to be. And so anything you can do to increase your autonomy, to give you more of a sense of control, will give you an advantage being a patient. And that's where education is so powerful. So this is a rough outline of what I hope to talk about. I'm going to talk about communication. We're going to talk about navigating treatment decisions. The details about treatment you're going to hear from, Dr. Treon's going to come after this and really tell you everything that's going on with specifics about treatment, but just how to approach a treatment decision. I'm going to talk a little bit about medical jargon, and because doctors, it's interesting. Doctors, sometimes they forget they're not talking to doctors when we speak with patients. And so how do we deal with medical jargon issues? And then resources we're going to hear about throughout the meeting, of course. So communication is a two-way street. And WM patients, again, should approach this relationship with their medical team as a long-term endeavor. And similar rules apply to other aspects of life. So we have to make sure not only that we talk, but that we listen. And equal time should be spent between those things. People have probably heard that when doctors go into a room with a patient, this has been studied in clinical situations in academic centers where they're taping physicians and patients or medical students and patients. And a doctor asks a question to a patient, what's the average time that goes by before the doctor interrupts the patient and drives the conversation? 30 seconds. And so that's not probably optimizing communication. So luckily we have savants in the field of medication in the lower right corner here, Bart Simpson in this example, who will tell us that we will effectively communicate with others, and that's a really important skill, not just for doctors and nurses, but for patients as well. So what are keys to good communication? This is an outline. I took it from a UCSF website. One is being organized. And we'll spend some time talking about being organized when you are a patient and when you come for your visits. Keeping good records. So it's really important to keep good records because, if you have pancreatic cancer and it's metastatic, you're probably not going to live very long. If your records are sketchy, not a big deal. But if you have WM, you're going to hopefully live a very long time, and you may move, and you may have different providers, and a lot can happen over 22 years is in Peter's case, or whatever it is, and longer for some of you here, no doubt. And so it's really important that you keep good records. And I can't tell you how often I'll see a patient who's been diagnosed previously with WM, and when they come with records, it's like, oh, this is just a godsend because we have all the data here, and I can give a really effective opinion about what I think is going on. Set the tone. And that's setting the tone for visits, and we'll talk about that some, and being assertive as a patient. But not only being assertive, but also being understanding, and we'll touch on that. Come prepared for your visits. And then don't rely on your memory ever, which is always write it down or record it. If it's important to you, you need to write it down or record it. So good organization. So plan for your visit with the doctor and plan for your best use of the doctor's time. Remember that the good ones are busy. If you call for your orthopedic surgeon and they have openings in 2 days or 3 days' time, that may not be the orthopedic surgeon you want, because if they have openings. And so the good doctors are busy. And so when you come, be prepared to take advantage of that time with them. Have your questions prepared in advance. And then it's also really, really important, and I love this when my patients do this with me, to make sure the doctor knows what your priorities are for the visit, what your priorities are, because it might be different than the doctor's priority. The doctor's priority might be, okay, I'm running a little behind, this guy's doing okay, I'm gonna get in and out of this meeting and move on, and you may have something that's really important for you to talk about, and we'll talk about how to bring that up with your doctor. And visits can be stressful. Some visits are very routine for our WM patients, but some are stressful. If there's a treatment change that needs to be made, if there's a side effect, if there's a real concern. And when you have stressful visits, it's really important to bring what I call extra ears. And extra ears are people that you trust who can just come and listen and be there to remember along with you. But also extra ears can be taking out your iPhone and saying, hey, can I record this conversation? here or writing things down. So extra ears takes a lot of different forms. And a really, really important tool that I use with my patients is sometimes I'll say, I'll talk to them and I'll say what I think, I'll give a recommendation and I'll say, so tell me, so what did I just tell you my recommendation is? And I'll make the patient repeat it back to me. And if they didn't repeat it back to me, that's not their fault. That's my fault. Because I didn't give them the tools to remember something important. So that is the voice back, the read back is a really important tool. So how about keeping good records? Let's talk about that. So keep a notebook. Everyone should have a notebook with WM, either paper or electronic. So I have everything that ranges from a few notes to the engineers who have spreadsheets and they're in like a 6 font going back 15 years with all kinds of lab data that I don't need, and then they have graphs of their Excel spreadsheets. So it takes all different forms. But what goes in there? Number one, your diagnostic information should be in there. So when you were diagnosed, you had blood work, you had a bone marrow biopsy, you may have had a scan. There may be a note from Dr. Treon or Dr. Castillo, Dr. Strosek, or Dr. Gertz in there that's important to have and share with your doctor. Critical labs should go in there, and we'll talk about what those are. Your treatment history should be there. You should know what you got, when you got it, how you tolerated it. All those things should be there. Critical notes from prior visits, and for this visit, and by this visit I mean I have patients who come in and they have their diary, and they'll come in and say, okay, here are the things I've noticed. My blood pressure's been trending up on zanubrutinib. What's that mean? And then it's really important that your doctor knows which medicines you're taking. And not just your medicines, but your supplements, because a lot of things that we do give to patients can interact with supplements and vice versa. So tracking labs. Now there's a lab session later this morning. It could be after Dr. Treon. Anyway, that'll get this in more detail, but keep a spreadsheet of your labs. That's what we do in our charts, and you should do the same thing. This gives you control over what's going on. And what do we track? Well, we track a complete blood count. And this is an example of a complete blood count on the upper right. I don't know if it can be seen. But when a blood count, it counts the white blood cells, the red blood cells, the platelets, the types of white blood cells, and all these things can be tracked. And this is really important because the number one reason that we treat WM is fatigue and anemia. And so anemia is a low red blood count. So you need to understand what your red blood count is. And over here, I'm going to test the pointer. I'm not going to test the pointer. Okay, so anyway, the red blood count, I just put there, it's red cell hemoglobin spelled in American, Paul, and hematocrit. And then ANC is a term we sometimes use for the good white cells. So that's an example of a complete blood count. We also test chemistries. And chemistries, you get a lot of stuff, but this is like the critical thing for the WM patients. This called the electrophoresis, or the M spike, or the IgM level. And you have to check those, and you have to track those. And so it's very easy to do that. And I love it when patients can bring in records of these labs. And of course, the IWMF, there's so much stuff on the IWMF website. If you just go in there and troll around, and you can find so much good information for helping you be a good patient, including this great term for a glossary of terms. So in this glossary here, it'll define M spike, immunoglobulin, light chain, hematocrit, hemoglobin. These things should not be foreign to you. You should be familiar with these things. It's all in that glossary. Other good communication tips. I often tell patients I cannot usually read minds, but sometimes I can, but usually I cannot read a mind. And so if something's important to you, you need to tell me. You need to tell me. And if there's something really important, you need to announce early in the visit that that's a priority for you, so the doctor doesn't get derailed and talk about something else. So this is being assertive. So if you have something that's really important for you to bring up at the visit that day, you need to let that early in the visit, you need to say, hey, this is really important to me. And if your doctor gets wayward and doesn't address it, you have to say, can we come back, please? and talk about something that's really important to me. And your doctor should hear that. Here's an example. The doctor says, I'm so pleased your M spike is down. Hey, do you need your medication? Did you get your medication refilled? And the patient says, well, I'm good there. I'm glad my M spike's down, but I feel worse. I'm having lots of side effects like joint aches, fatigue, bruising, and it's very important that we discuss that today. So you're directing the doctor to address what's really important to you. But also be understanding. Some of the things that we bring up with doctors probably can be handled by somebody else. So if I'm really busy, I probably don't need to fill out your jury summons excuse, but I'm happy to do that. But some things can go to some of the other staff there, so be understanding if your doctor is busy. And then again, the last point there, if something's really, really important, then ask your doctor if you have the visit recorded. Some docs are just not comfortable with this, and that's fine, but I'm comfortable with it. And so I think that, and it's so simple to do on your iPhone to record something and keep it for posterity. It's really important, especially if your significant other's not there. If you want to go home and hear it again, what the doctor said, that's a very easy thing to do. Okay, so I think this is really important, a really important point. And I'm not going to talk about specifics of treatment, but I'm going to talk about how we, as patients and physicians, navigate a treatment decision. And I call this a treatment crossroads. I use the term treatment crossroads when you're sitting across from a patient and we need to do something. We're going to need to either to start treatment or to reinitiate treatment or to change treatment. I call that a treatment crossroads. And when you have a treatment crossroads, there are a lot of things that we do. And what I do is I use the analogy of going to a Mexican restaurant and getting the menu. You know, they have those 12-page, big with the picture Mexican menus, and so it's that way in WM now. We have a lot of treatment choices in WM these days. And so when we're at a treatment crossroads, we have to go through all those and decide what pros and cons of each of those are, and to discuss that with our patients. So this is where it's really, really important to have to either record or write down or bring extra ears and that kind of thing. The other thing I'll tell patients sometimes, if it's a really big meeting, is like, okay, we may need more time. This visit may need to be longer. And so I don't know, some doctors have 15-minute appointments, which is really, I think, challenging to talk about important things in 15 minutes. Other visits are longer. And so there are times where I'll go to my staff, I'll say, look, this is a really critical thing. This is going to take a while. We're going to bring up a clinical trial and go through that. And this needs to be an hour-long appointment. Sometimes that's the case, so it's not hurried when there's a treatment decision. So what questions do we ask when the doctor is saying that we need to alter, change, or initiate treatment? And well, one is, what are my options? What are the pros and cons of each? It's really important that we understand that. So if a doctor says, you're getting this, and it's one thing, and you're only being presented with one thing, that might be it's probably the best thing, but it may not be. And you need to hear what your other options are. So what are my other options? And then another one is, should I get another opinion? And so if you are fortunate enough to live not too far away from people that do WM as a specialty, sometimes it's nice to go get another opinion, or you can sometimes ask your doctor if they have another opinion. So I often get calls from other docs in Colorado who know of my interest in Waldenstrom's, and they'll say, hey, I got this person here, this is what I've done, this is what I'm thinking, what do you think, and do you have any clinical trials? I get calls like that with some regularity from docs in Colorado. And then, are there any clinical trials? It's really important to talk about clinical trials because right now, just at our center, we have 3 trials open right now, 4. We have 4 trials open right now for Waldenstrom's patients at various stages of their treatment. And these are things that are not yet approved by the Food and Drug Administration. And so these trials, you ask about them. Now, how do you find out about these? Well, one way is to go to clinicaltrials.gov. Which you pay for already, and it's a site where you just go in there and you can say, okay, I want to look for a Waldenstrom's trial, and it'll pull up all kinds of trials there. And the Leukemia Lymphoma Society, they have a booth out here. The LLS, and I'm a great believer in what they do. They have clinical trial navigators, so they have nurse navigators, and you can just contact them and they'll start walking through and doing research on your behalf, looking for clinical trials, which is really, really, really good. And then you're going to hear later today, probably from Dr. Castillo, about WMNet. WMNet is a research network in Waldenstrom's that I missed the meeting yesterday afternoon because I was golfing with my wife. That WMNet is getting serious traction, and trials have already been initiated in WMNet that are cutting edge. And WMNet is comprised of several centers around the country that are very interested in Waldenstrom's research. And so, and then if you go to the IWMF, if you're looking for a WM doctor, there's a list of IWMF experts in all the different states and areas of the world. You can go there and find information as well if you want to reach out to them. So there's a lot of ways you can get information about your treatment options. And with rare exception in WM, we have time to navigate treatment options. Sometimes treatment is urgent, and there may not be so much time to do all this research, but normally in WM, we have time to navigate these. And it's important when we talk about treatment decisions, not just to talk about efficacy. Efficacy is how well something works, but we have to talk about side effects and also what they cost. Cost is a reality, and I still have patients these days where I have to make a treatment decision in WM based on cost. And another thing in WM that's really, really important is in the absence of the accepted symptoms and signs for starting treatment, it's always reasonable to defer or delay treatment. Meaning that if your labs are going up, but you still feel like $1 million, then it's not an emergency to treat you or to intervene. You have time to sort things out. So keep that in mind. Okay, this is the most difficult question that I get. And I don't recommend that you ask your doctor this question. Because frankly, your doctor doesn't know, and I don't know. And I can't tell you how many patients I've seen in second opinion who had a WM diagnosis and were told that they had X number of years to live. Okay, so just a show of hands, who was told here how long they have to live when you were diagnosed? Yeah. Oh, okay. Can I just single out this guy here with our former chairman? Carl, you were told what and when? 2006, 3 to 5 years. So when patients tell me that, he said 2006 he was told 3 to 5 years, I just tell them that's in increments, and so you get to renew, and you got to keep renewing that policy over and over and over again. And so again, I'm only good at this at the end of life. And so with myeloma or the other diseases I treat, I'm pretty good if someone is getting close to dying of giving an estimate. Otherwise, I'm not good. And if you ask, you might get a stock answer that doesn't even apply to you. And then that just sits there with you the whole time, right? Just sits with you the whole time. The doctor said, I have this many years. I'm not going to get a colonoscopy if I've only got that many years to live, or I'm going to quit paying my mortgage or whatever it is. And so, and doctors, including at this conference occasionally, love talking about survival. And we show you our research studies published in our journals with these things called survival curves, right? You see them all the time. Or your doctor gives you a paper. Here's a paper I published, and here's the survival curves. And you have to know what to do with that information. So I'm going to give you some tips on that. Those are called Kaplan-Meier curves. But don't ask us this question. Okay, so WM treatment, get informed. Number one, ask about side effects. Because I think Herman has the best doctor comics. Anyway, I still learn about new side effects from medicines that I've been using for a long time. And so one example is zanubrutinib. So zanubrutinib, a commonly used BTK inhibitor. And so we were lucky enough to be studying zanubrutinib before it was approved by the FDA, and we've been involved in studies that have been really important and published and everything, but I still don't understand completely all the side effects from zanubrutinib. And so for me, what's really challenging for me as a doctor, sometimes if we didn't report it in the study, let's just say a patient comes up and says, my ear turned orange. I'll just Give that as an example. And I say, well, look, here's the paper right here, and no one in the paper reported that their ear turned orange. It must not be the zanubrutinib. Okay, that's me. That's what I say. But in the papers, these studies are often done with 100 or 200 patients. And then when something gets FDA approved and broadly used, and you treat thousands and thousands and thousands of more individuals, the more unusual side effects begin to emerge. And so it's possible that even though I tell you that I don't think this side effect is due to my medicine because it wasn't in the paper, it's very possible it was due to the medicine. So just always keep that in mind, and it's a good humbling thing for doctors to keep in mind as well. And also make sure you have understandable instructions how to take the medicine. So when I write a prescription, I was taught as a medical student, if you write a prescription for amoxicillin, an antibiotic, and you're treating strep throat, on the prescription write one PO, one orally 3 times a day to treat strep throat. Write it on the prescription so people, when they pick up their pill, they know what it's for. Or write it on a piece of paper. I'm giving you this medicine for this effect. And we know that I've given confusing instructions on how to take medicines before. I love this one. Take one of these with water a half hour before you wake up every morning. I'm sure I've done that to patients. And so when a medicine is given, you double check how you take it. And we know that this is a study from India, actually. And it's going to be hard to read the type there, but this is done in, they called it geriatric patients, and I would fit the bill here. It's 65 and over was considered geriatric. But they looked at medication errors if the medications were explained very well to patients. That's on the left side. Versus if they weren't explained very well to patients. These are medication errors. And so explaining medications is really, really important, especially if we're giving people things to treat their WM. I love talking about medical jargon. Okay, so I'm just gonna, what we say to dogs. Okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger? Stay out of the garbage or else. That's on top. What is Ginger here? Blah, 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 Ginger, blah, 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 Ginger, blah, 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 Ginger. And it's the same way sometimes when we talk to patients. And so here's I just made this one up, but it's probably pretty close to true for many of us. Okay, so we have PD here on a BTKI, and I think we ought to change either to a non-covalent BTKI or perhaps a BTK degrader. Maybe BCL2 inhibition might be the way to go because it's anti-apoptotic, as we all know. And we have these new T-cell redirecting therapies I think are really, really exciting. What are your thoughts about this, Mrs. Jones? You know, and so doctors sometimes, we do that, right? And then here's one. I'm going to give you a treatment. And why do I want to give you this treatment? It's obvious. The median PFS has not been reached in the treatment group, and the OS looks really favorable also in the duration of response. Of course, that's why I'm going to give you this treatment. And the patient's sitting there going, patients like Ginger. Okay, so we're going to talk a little bit about oncospeak. So oncospeak, and this is just being proficient in WM, and you know, Dr. Hunter spoke yesterday, and when Dr. Hunter speaks about the genetics and all the science in WM, you have to realize this is coming from someone who's been recognized internationally for his expertise in this field and knows so much about this. And I'll give you a very personal example. So I had to speak at a conference in April, and I was talking at the WM doctor workshop last October. There was some pretty cool stuff that got presented on different subtypes of WM and the basic science behind it and that kind of thing. But I'm a clinician, I'm not a basic scientist, and so a lot of it, I was like Ginger, you know, right over my head. But I wanted to present some of it because I thought it was really important. So I called up Dr. Hunter. I hope he's not in the room because I'm going to embarrass him. And he spent about 45 minutes on the phone to me, walking me through his slides and trying to explain to me in terms that I could understand what he had presented at the meeting and what was going on. And I kind of got it. With these terms, so these are all terms here that you hear over and over and over again, but these are really, really important terms for WM patients. And so you have to keep practicing with them because they're not things that we learned. And so one thing we talk about is mutations. And mutations, when people hear mutations, sometimes we think about, sickle cell disease. That's an example of a disease with a mutation that we're born with. Okay, so that's something we're born with. So those are mutations that are passed on from parents to children. And in WM, we don't talk about those kinds of mutations. We talk about mutations that you picked up along the way. You didn't have them before, and you got them now, and you got them because of bad luck. And so the two big mutations we talk about are MYD88, or mid-88, people will often call it, and CXCR4. And when you hear about those mutations, often you'll hear doctors say, well, you're a wild type mid-88. That's quite unusual. And what does that mean? Well, wild type means there's no mutation in the MYD88 gene. And that is a quite unusual event. And then mutated means there is a mutation in that gene. And 95% of the WM patients have mutations in the MYD88 gene that drives the development of the Waldenstroms. Now, CXCR4 is another mutation, and that's mutated or altered in about 40% of patients who have Waldenstroms. And so when we talk about this, we'll say, well, this guy's doctors will talk to each other and say, hey, I got a guy who's mid-88 mutated, CXCR4 frame shift mutated. And we'll know that's a language that we have that we talk about, and we know what each other is saying. But it's important to know about mutations. And so the other thing about mutations in CXCR4, sometimes it's called WIM. MYD88 is sometimes called L265P. And then mutations in CXCR4 can be nonsense or frame shift as well. So these are just things that are out there. And I've actually used these terms with patients before, especially the ones that like to get into the weeds. I'll say, you have a nonsense mutation in your CXCR4 has a nonsense mutation. The BTK inhibitors may not work quite as well for you. We're not sure about that. And maybe we should think about giving you chemoimmunotherapy. And that's a discussion that we sometimes have with patients, but it takes a lot of work to get there and be able to have that discussion. And so, again, look at everything that I talked about. MYD88, CXCR4, blah, blah, it's all in that glossary of terms. And so I love this. When a doctor shows you this, okay, who's ever seen this at conferences or from a doctor? This is from the ASPEN trial. The ASPEN trial was a really, really, really important study. It compared ibrutinib to zanubrutinib in patients with WM. A great study. It's been published a few times. And in 2023, there was the final publication, updated information from this study. And this is a graph from that study. So this is when doctors talk about response rates. If doctors show you this. And so just an example here, so zanubrutinib and in different columns is on the left, ibrutinib is on the right, and these are responses that occur in time over patients who have the MYD88 mutation. And so if you look at that, you go, what does that even mean? You know, because it has the PD, SD, MR, PR, VGPR, those are the responses there. And I don't even know what that even means. And so it's the doctors show you this all the time, right? So we have terms for this, and I lifted this right out of the WM glossary of terms from IWMF. So right, and this is when we talk about responses, and I don't want to go over every one of these, but a complete response, which hardly ever happens in WM, is when you have complete disappearance of the WM from the bone marrow and you can't find it in the bloodstream either. That's a complete response. We don't see too many complete responses in WM. We really don't see them at all with the BTK inhibitors like ibrutinib or zanubrutinib. You might occasionally see them with the BCL2 inhibitors like venetoclax. You see quite a bit of it with bendamustine Rituxan, sometimes with Velcade Rituxan. But complete responses are unusual. But when you get them, boy, those patients do really well for a long period of time. A very good partial response is if my IgM was this high, did I decrease my IgM by 90% or more, but not quite the 100%? And that's a very good partial response. Those patients do really well too. So if we go back a slide, the CRs, they don't even show CRs, but their CRs are in red. So look at the far right there. And you see there's like one patient who had a complete response in this study in the red, the very right column. But there were quite a few VGPRs and partial responses. And those are good responses. And so anyway, That's language that you often see when doctors show you response rates. But the other thing you remember in WM is, as I call WM, a threshold disease. So when we treat WM, we don't have to make the WM go away to make our patients feel better. You just have to knock it below a certain level where patients have good quality of life, they feel normal, and that's the response we're looking for in WM. So all these things are great. Doctors love to show them, but at the end of the day, we just have to make you feel better and hopefully live longer. Okay, survival curves. Okay, I'm going to show you some survival curves. So doctors love to show these, and here it is right here. Here are a couple survival curves from the same Aspen trial here. Progression-free survival and overall survival. So what the heck does that even mean? So these are Kaplan-Meier curves, and these are estimates. And so if doctors show you this, you have to say, well, first of all, what do these even mean? So PFS is I haven't relapsed or died. And overall survival is exactly what it says. That's dead or alive. And so, and they compared zanubrutinib in the red line to ibrutinib in the blue line, and it looks at progression-free survival. And so what that is, this is an estimate that over time, if patients relapse or if they die, the curve goes down from 100% and starts working its way down. And if everybody were to die or relapse, the curve would be all the way to the bottom. But if they're doing okay, the curves stay pretty high up there on that chart. And that's what progression-free survival is. And so there's something called the median progression-free survival, which is the time that it takes for half the people to relapse. And it's very often doctors will look at progression-free survival, and that's where they get the number of how long they think you're going to live. If you ask them that stupid question, not supposed to ask them, how long am I going to live, doctor? But if you ask them, more often than not, they're going to look at progression-free survival, the median, and give you that as a number, and it probably doesn't even apply to you. And so on the right is overall survival. So what are Kaplan-Meier curves? Well, don't let your doctor show you Kaplan-Meier curves, but if they do, a Kaplan-Meier curve is an estimate of something occurring over time. And the horizontal axis is time in years. The vertical axis is the probability of people surviving, or the proportion of people surviving. At time 0, everybody's alive. And then over time, people start to relapse or die. And then the curve starts going down. And when it hits 50%, that's called the median. This is not a curve for WM. This is an educational curve. This is not you. This is not Waldenstrom's. This is not any treatment. This is just an example of a Kaplan-Meier curve show. And so when people ask me, how do I interpret this? I say, well, these Kaplan-Meier curves apply to populations of patients. Populations of patients. So if we look at the whole room here, and we did something to everybody here, then some people would do really well with the treatment for a while, some people would do okay, and some people would not do as well. And the Kaplan-Meier estimates sort of give us information around this. However, if one patient in the room raises their hand and says, where am I on that curve, doctor? And the doctor gives you an answer, the doctor has no clue where you are in that. They have no clue for an individual. These apply to populations, not individuals. So that's why we can't be applying Kaplan-Meier curves in the patient room with them, in my opinion. Okay, here's some more onco speak here that you'll hear about later, probably from Dr. Treon in a few minutes here. One is BTK, that stands for Bruton's tyrosine kinase, which is an enzyme inside B cells that affects how the B cells develop and how they work. It's turned on, it's cranked up in WM, and therefore it's a good target for certain treatments in WM. These are called BTK inhibitors. And we also are learning more about a protein called BCL2 that stands for B cell lymphoma 2 protein. And this is a protein that inhibits cells from dying when they're supposed to. Another term for that is programmed cell death, or apoptosis, which most medical students can't spell. Well, that's what BCL2 is. So we have BCL2 inhibitors that are out there in development as well. So when Dr. Treon tells you you could have a BTK inhibitor or a BCL2 inhibitor, maybe you'll have a little bit more of an idea what he's talking about. Okay, resources. There are great resources out there. You walked by several of the tables when you came here for the meeting. Of course, IWMF is tops for patient support resource for a rare disease. LLS is also fabulous, especially for the Clinical Trial Navigator, to which I referred earlier. Lymphoma Research Foundation, and then for Paul, I included the WMFC, the Canadians, for their, and I capitalized Friends, of course. You wouldn't believe, I haven't lived in Canada for over 60 years, but all my Canadian relatives, you would not believe the texts and emails that I was getting recently. And then we have our Canadian family reunion coming up the end of August, and that could still be pretty interesting. And then the patient registries. You heard Peter talk about the whimsical, and it's super important, I think, to participate in these registries. We learn so much about them. So with that, I'm going to wrap it up and say thank you to each and every one of you. And then, if need be, we have a couple minutes for questions. Is that how we're doing it, Paul, or are we just moving on to Dr. Treon? Okay.
Okay, so a couple minutes for questions. Anybody have a question?
This was very, very good, informative. How can we get physicians to listen to this talk?
Physicians are all taught in medical school about communication. But I was also taught about neurology. And I don't remember anything about neurology because I didn't like it, and so I think that it's hard. There is a IWMF publication that correct me, Peter, Carl, Paul, about giving your doctor who may not have many WM patients information about WM. There is a publication through IWMF for that. Yeah,
yes.
And that's one thing you can try. But if you're gonna have a long relationship, you can also train your doctor, and just sort of say, hey, just use those tools. Hey, this is really important to me. I need you to talk about this, or I need you to write that down for me. Doctors are trainable. Most, yeah. Okay.
There are also a couple of things that are in the information pack for the newly diagnosed, written by Maury Gertz, about how to talk to your doctor and how to prepare for your doctor visits. So they're on our website too.
FYI, I saw Maury running to catch his shuttle back to the airport dressed like a Mayo Clinic doctor yesterday. Black suit, white shirt, tie, 90 degrees out, running to the car. Yeah.
You talked about recording. It's something that cropped up in the UK last year in a webinar we had where somebody advised us about that. What would your response be if you met a physician who said, "No, I don't want you to record this"?
I think that's probably a common response to that request, right? I would say, then can you write down the critical parts of what you're telling me? And I keep a pad and paper in every patient room where if there's something important, I write it down for the patient and just say, please write this down for me, and that's what I would do. It's important and hopefully legibly.
How important is that hard copy of your records?
Which copy?
A hard copy of your records.
Oh, I think it's important, not every lab, but critical ones and tracking it, I think it's important because the odds are really good that you guys are all going to have your disease and your lifespan is going to outpace the time your doctor's in practice. It's a real possibility, right? If you have your disease for 20 years, you might be having to switch doctors 2 or 3 times. And if you have those records, it's really, really nice to have those records. I got to tell you, as a physician, it's wonderful when patients come in and they have everything right there. It makes it so much better for us and therefore you.